Hi, I'm Lily Newman. Welcome to Viewpoint Part 2 with Commissioner Arlene Sanchez Gonzalez of the New York State Office of Alcoholism and Substance Abuse Services and Robert Kent, Chief Counsel of New York State Office of Alcohol and Substance Abuse Services, and my co-host Susan Salomone.
Hi, Lily.
Hi, welcome. So what we were talking about during the break was about 1,000 things. And we started talking about Governor Cuomo and the legislation that he signed in 3 different, Long Island, Buffalo, and Staten Island, how exciting it was, and everything, the changes that are being made out there to help. So you want to talk about?
Yes, well, the listening sessions that I was involved in with Commissioner Sanchez and Robert Kent went to 8 different areas in the state, and each listening session had 3 people, experts from that area, that spoke about different things about that particular area, and then community members that came up and spoke about how, if they were governor, what they would do to stem the tide of this heroin epidemic. And it was very enlightening, because in each one of the 8 places we went, you started to see patterns of the same things coming up over and over again from the community. And from that, Governor Cuomo signed multiple bills into law on the 22nd of June, and maybe Robert Kent can tell us a little bit about what those laws are, what they mean to the individual that's dealing with right now, and families that have issues with substance use.
Sure. So, yeah, and they flowed from the listening sessions and from what we had heard both before and after, but amongst the things we heard was that insurance barriers were still a problem. So in other words, people having difficulty accessing treatment and getting their insurance companies to pay. And so, and the governor did a really good job of zeroing in when he talked about to me, the biggest bill. So I'm a lawyer, I'm a nerd, I'm a whatever, I'm a word guy. But the tools they use to make decisions about where people go to get help, that's the ball game. So, and he focused in on that, right? He talked about if a doctor asks and goes through a series of questions and decides that this is the right place for the person to be, then that is what it ought to be. And so our boss, my boss, the commissioner, now gets to pick the tools. The tools need to be consistent with our system, our levels of care, and we've already written our own tool. We hope the world, it's called the OASAS locator tool. It's mandated in Medicaid managed care. We would hope the whole world will go to it. It is possible for you to use something else, but there's a much higher bar now to get over in order to use something else. And the highest bar is that the commissioner gets to decide whether or not you can use it. So that was one piece. Well, we also heard about, and the bill impacts, is, I call it waiting room withdrawal. People seeking inpatient care with them, with their families, sitting in waiting rooms of inpatient programs for up to 6 hours, waiting for an insurance company to say you can stay and go in, or you can't. And I mean, at the end of that 5 or 6 hours, you're starting to withdraw. Or you're still continuing to use, either in the program or out in the parking lot. The family's there. It is just not a great situation. So what the governor did was, so first off, the rule now after the federal parity laws, is you are entitled to all care that you need that is medically necessary. That's why the tool matters. The tool tells you what's medically necessary.
Exactly.
But then with regard to inpatient treatment, when I say inpatient, I mean detox, I mean residential, and I mean inpatient rehabilitation. You go now. There's no prior authorization. You can go to treatment. The provider has to use, ideally, our locator tool to say that's the right place for you to be. And then the insurance company can't come in and start looking at whether you need to still be there
Right.
until the 15th day. So the first
It's
14
amazing.
days, you're going to be in treatment. It's no other state in the country has gone to this point. But 14 days is a great amount of time to help somebody become stable medically, you know, detox off of the drugs
Right.
they've been using. But then even then, to determine whether you stay, they're going to use a tool that the commissioner approves to make those decisions. So
That's great.
so the system now,
It's a system.
the leader of the system controls
That's right.
how medical, clinical
Right.
decisions are made. So those are the other big piece on the insurance side was access to addiction medications.
Yes.
And what we see, especially with the heroin opioid crisis, medications, especially at the beginning, are almost essential
That's right.
to help somebody. So I'm talking about buprenorphine, injectable naltrexone or Vivitrol, and methadone. And so now what we did in the bills, for Medicaid, there's no more prior authorization at all for buprenorphine and for injectable naltrexone. So you don't have to wait 3 days,
Right.
whatever, 5 days for the insurer to say, yes, they can have the medication. A lot of times they leave the program. If they
That's
leave,
right.
they aren't going to take the medication.
That's right. You lost them.
And then on the private insurance, we say there's immediate access to a 5-day supply for emergency conditions. And the emergency conditions, we will define what that means. I can tell you one of them would be leaving one level of care and going to another. So people will get access to inpatient treatment if they need it, and to the medications if they need them. So those are the insurance pieces. And I won't hit all the items, but some of the other more important ones, we're going to require hospitals to do a better job and have policies and protocols as it relates to discharging people from hospitals. So many folks who are dealing with heroin, opioid, reversed on Narcan, run through emergency departments. The linkages to treatment
there.
don't happen. Other huge piece, prescribers of opioids are now going to have to be educated
That's right.
on use of opioids,
right.
how addictive they are, on treating people with addictions. That's
right.
another element of it. And then educated on how to use alternatives to opioids.
It's huge.
And then the last key piece is we limit for acute, well, actually there's another piece I want to talk about, but it's sort of on its own. We will now limit initial prescriptions for acute pain for opioids to 7 days.
Good. That's right.
And to be clear, it still leaves to the prescriber the judgment to determine whether it's really an acute condition or it's not acute.
Right.
Right.
And then we specifically exempt in the language chronic pain, palliative care, cancer
right.
care,
Right.
end-of-life care.
Absolutely.
So
Okay.
this doesn't impact their ability
Right.
to get prescriptions. The last piece I want to mention, because it seemed to get the most attention, is the ability for families to access 72-hour emergency
right.
services for
Yeah.
their
Right.
loved ones.
That's
That
right.
was very big.
Certain folks believe that we're violating people's civil liberties. I think the governor specifically talked about it's a balance, and he balances towards saving people's
That's
lives.
right.
The one thing we know is if you don't intervene, the drugs they're using, they're dying at
That's right.
record numbers.
Right.
So that kind of intervention was necessary, and I know that piece has been really critical to the commissioner, so I don't know if she wants to talk about that piece in particular.
Yes, it was. And I think it's important that people understand it wasn't meant to be as a punitive model of care, forcing people into treatment. But better yet, having the ability to work with someone who obviously is not stable enough
Right.
to make decisions maybe a danger to themselves or others, get them in a place where we could start medicating them and treating them with the understanding and the hope that they will agree to continue treatment, rather than what we do now, which is you get stabilized supposedly in the emergency department and you're sent off. I think now we have the ability to work with the individual, start them on meds so that they don't go into withdrawal, and hopefully get them to agree that they will accept treatment and move on. That was very big for me. You know, as a parent, you know, it's huge. And everywhere I went, and Susan, you were part of the task force, you heard parents saying, you know, if I had a place where I could have taken my child, you know, it would have been maybe different. So, so yes, that was one of the biggest pieces for me, as you know.
I think it's great. Now, I have a question about that. Can a parent bring a child somewhere, even if it's an adult child, and say, I want you to keep him here for 72 hours? Or does it have to be after having Narcan or after an overdose? Or
It's not limited to Narcan. No. And actually what happens, we're trying to, so there's regulations that are going to be written that we're working on. The commissioner, it's not every place either. It's not every program. Because not every program's equipped to deal with somebody who might be that incapacitated. So the commissioner's going to designate the programs. Could include hospitals. It'll most likely include our inpatient level, our higher level residential programs. So there's that piece. But and ideally what we're looking to do is have them brought to a treatment program, not brought to the police, not brought to the local mental hygiene director, but brought directly to a treatment program, and let clinicians in a treatment program and the family and the person work out
the way
what's
the way we're envisioning it is not to have someone taken by an authority figure, a police or a sheriff or anyone of that nature, to an emergency department. The idea is to have them taken to what we're going to call like a crisis stabilization unit in the community, you know, that's run, maybe certified by OASAS, not to the emergency room in a hospital, and have that facility work with the individual. It's not about coercion. It's about just agreeing to take the individual there and keep them there and work with them, stabilize them, and
give them
so
some
on and so
time.
forth.
give them some
In
time.
a safe place.
Well, and the thing is,
And help the families
are so
too.
involved.
And help the family.
Most situations, it's not a person walking in off the street on their own. The
Families.
families are involved.
Yes.
And that's why I say the insurance piece is this piece as well. Our experience is that nobody's 100% bought into going to treatment when they show up and say they're ready. So if you put obstacles up, they will
use it.
It's an excuse. Well, this wasn't meant to be, whatever. And actually, I'll point out, we sort of jumped it at the Staten Island Listening Forum. We had a mother stand up in the audience who said her daughter needs help and her daughter's ready to go to treatment. Now, we had staff from our South Beach Addiction Treatment Center, which is on Staten Island, and they did that intervention right there, and she came to treatment the next day. So...
And I was told she finished and she's doing well. And so those are the kinds of intervention. And one other piece is that, and I'm sure you've heard it as we went around, some individuals themselves who spoke about their experiences have often said, if it wasn't because I was mandated by the criminal justice system, I wouldn't be here. So what I'm trying to do is do away with that mandate from criminal justice and have a facility where a loved one could take them and say, here.
Right.
That's not coercion.
Right.
Coercion
Right.
is when you're mandated through the court
Right.
system to go into treatment or go into jail.
That's right.
And then
Right, and that doesn't always work out
Right.
that,
No.
that well. I mean,
Yeah.
I know parents that have had their children arrested in the hopes of getting them in treatment
That's right.
court, and they wound up in jail
That's right.
for
Right.
years,
That's
for a couple of
Exactly.
years, 2-3
Exactly.
years. I mean, and that was
Exactly.
never the intent
Well,
of
and
the
if it's a
parent.
local jail, they're not
Exactly.
getting any treatment.
Right. That's right.
Right. So that was really the emphasis
Yeah.
behind this 72-hour intervention.
Right.
That it's not a hold.
Right.
It's a crisis
It's a breathing,
stabilization.
right. And
Crisis
it's-
stabilization.
right.
That's a great name
That's
for
right.
it because
Well,
after
yeah.
that, after 72 hours,
Start to
most
breathe.
people. I mean, my son would have gone to that because it was only 72 hours. Well, I'll do it for 72
Well,
hours,
hopefully he would have been
and then
convinced to stay.
at that
'Cause
time.
And
that's the
engaged.
piece, is that
Right. You have
our
the
medical
engagement.
director, Charlie Morgan, he talks about, you got to understand what a good program does, which is they don't judge you. And
Exactly.
as he said, and Dr. Morgan's in recovery himself, and he said, nobody can tell somebody who's at this point anything that makes them feel worse about themselves
That's
than they
right.
already
That's
feel
right.
about
Right.
themselves.
That's
right.
true.
So it's bringing them in.
Right.
How can I make you comfortable?
Right.
Our
right.
medication's in order. I'll address the withdrawal symptoms, and as well, it's counselors who aren't your family, because
Right.
we've seen the family
Yes, that's-
dynamic as
yeah.
well.
Right.
I'm tired of hearing from my mom,
That's
dad,
right.
brother,
Right.
sister. Well, I'm not them. You have a problem. You will kill yourself eventually if you don't get help. But so we think there's other stuff we're going to do, but we think it is an alternative in some instances for people who are just truly in crisis.
Right.
And
Yeah.
the civil libertarians, I say it, they've never talked to the parents.
That's right.
Right.
Of who lost
And
their
they aren't
children.
a lot of the times parents who've gone through what you've gone through and what we've heard from other parents all across the
Right.
state. So walk in their shoes when
Right.
you want to sit there and
Exactly.
talk or judge why they're
Right.
saying what they're saying. So
I know it's sticky. It's a sticky area that they have rights. They're adults. They can make their own decisions. But in reality, they can't.
Hey, how can you?
because
You're out of your mind with drugs.
Right.
If you
You're out
are-
of your mind.
well, that's the,
you know,
the key
and that's
piece.
the thing.
A doctor has to say you're incapacitated
Exactly.
and incapable
word.
of making decisions.
Right. Right.
And that you are dangerous to yourself
That's right.
and others. So it's not just, well, we
Okay.
think
Right.
you're highly addicted.
Right.
You got to show it.
Right.
And we don't, if we do all the other stuff right, it's a last resort and isn't used as
Right.
that much.
Right.
But it needs to be available.
Right.
Right. It has to be made available.
Right.
And
so when do you think these is that the last of the bills that was signed into law?
Yes.
Those are the key pieces.
Those are the key
Um,
pieces.
There are
the-
11 of them, different
There
ones,
were
but
11
those were
elements
the
in
key.
the 3 bills. But the insurance pieces take effect January 1st.
Okay.
But as I say that, we talk to insurance companies all the time. And they're like, you've got to do this in a few months. Why don't you get a
Still
jump?
now.
Why don't you get a head start? I'll give you a great example, too. So the 2014 laws that were passed,
Right.
which led to the work group, which you're also part of, the
Right.
insurance work group, right? We limited to 3 tools: OASAS locator, the ASAM tool, which is the American Society of Addiction Medicine, and one insurer, Excelis, in the Western New York area, used a tool called Interqual. We let them use it. We've monitored them. We're not entirely happy with how it's gone. They just notified us as as everything was going on. They're moving to Locator as of September 1st.
Oh, good.
So
That's great.
Yeah.
an ASAM to be continued is going to have to make some modifications because it doesn't. What's happened with ASAM, and this is again, it's experience. The first laws were 2014. This new version is that much more. But what we saw with the ASAM tool is they don't have a because it goes in levels of need or levels of care. they don't have a comparable level for our inpatient or residential
Got it.
level in the community. So then what was happening is people were being defaulted to intensive outpatient,
Right. Got it.
outpatient. So it was sort of a backdoor fail first.
Right.
So
Okay.
they've got to make adjustments in order to be approved to continue
Or
on.
to switch to the locator.
Or switch.
So I'll make a pitch for Locator.
Locator.
We created it.
Right.
It was created by OASAS clinicians with clinicians in the field. It's web-based. It's free. ASAM and others cost you money. They're proprietary. It takes 6 to 8 minutes.
And
To
it
make a
really does. You
decision.
answer A, you go here,
And
here.
It's being used now by Medicaid managed care. So we have a lot of experience because Medicaid managed care started in New York City in October
Right.
of last year. Over 200,000 uses, 90% agreement. The insurance companies tell us the time it saved them, and they like using the tool.
That's
So-
good.
And that's good. So,
So
you
we
get
hope,
less resistance.
so we keep saying, well, why not use it for all your products?
Right. So we'll see.
But
We'll see. But they
Right,
got
doesn't it
they got
make
a
so much
steeper
more
hill to
sense if
climb
does.
now.
Right.
They have to use it for Medicaid. Why not
Right.
use it for
Well,
everything?
that's
Well, is-
what we've been saying.
Right, because regular insurance companies, don't they have to use the locator?
They can use Locator or ASAM
ASAM.
Or
Okay.
Sam.
Okay.
right now, but that's changing. One of the bills is
Got
going to
it.
change
So
that.
even the insurance companies have to use
Oh,
the
yes.
Okay.
Well, it just makes sense as long as it's a web-based product that's
Right.
working. Why
To have one tool
One tool. It's
for
just a
everything.
benchmark.
Well, the thing is, it's web-based, so you understand. It's housed, so every time the tool's used, it's housed in I'm not a tech guy, a portal or like a data place by the Department of Health. So we have access, and we're going to be, and we look to see that it's being used properly, because both from, and when I say that, we're monitoring how insurers using it, we're monitoring how our providers use it, because we don't want them playing games
Right.
with this either.
Right.
We want people to get the care they need that's medically needed, not just that they get care.
Right.
So to be clear, I just got to say this on the 14-day thing because some people are misstating it. You are not entitled to 14
Right.
days of care. You're entitled to care that you need, and they can't start looking at where you're at if it's inpatient until the 15th day. But you need to be there.
Right.
What do you mean?
You need to use the tool.
Right.
It needs to be medically necessary.
Okay.
We expect our providers to continually monitor whether the person still needs to be at
Right.
that level, even
Okay.
during the 14
Even
days.
during the 14
The
days.
difference,
Okay, all right.
see, here's one
I
of the
see.
big key pieces. Our programs are not richly staffed. They're not huge operations. They don't have a backroom set of staff that only talk to insurance
Right.
companies. If you're going through an interaction with an insurance company, it's the same doctor, nurse, social worker that treats the patients are on the phone with the insurance company.
Right.
So we're freeing them up as well to focus on treating the people
Right.
and not doing those kinds of things. So
Yeah, I know. When I was over at OMSACS this summer doing an internship, and the case managers were on the phone a lot with the insurance companies. I thought, really, this
Spend a
is
lot of time.
really too much time
lot of
on the
time.
phones. They should be the time they could be using for patients.
Right.
And so that's a really big benefit of
Yeah.
the 14-day.
yeah.
And I have to tell you something. There are people that are on the phone with insurance companies and they use the locator, and the insurance companies are still fighting them. And they say, what do we do now? So my question is, I know it doesn't go into effect till January. So what is the recourse that a program has or a family has if they meet the criteria and the insurance company goes, we don't have to use it yet, or I'm not using it?
A really good example. So a couple different things. If it's Medicaid managed care, they have to use Locator.
Okay.
So if they aren't, you need to let me know.
Okay.
Right.
We will talk to them about that.
Good.
Private insurance, right now, it's still encouraging them.
Okay.
But there's an important piece. If you were denied care, even now, right, with it being more than one tool, you have a right to appeal. And the provider has a right to appeal. And you should take advantage of those rights. And in fact, you know, we've posted videos on our web explaining to people how to exercise their rights to challenge those decisions. If a clinician in a program thought you needed to be there and the insurer disagrees, you ought to challenge that.
And while you challenge it, you're supposed to stay in the program until a final decision is done, and the insurance company will have to pay. So it's to their advantage to come to a decision fairly quickly. But even in those instances, we always tell folks, let us know.
Right.
You know, we can't intervene or we can't help if we don't know that that's happening.
Right.
So, and we have a unit in the department that is really working on those
the
issues.
number.
Yeah.
Because we got parents that are in the waiting room with insurance companies denying their children's care or their family members' care.
Well, we hope that becomes a lot. So I'll give you better. So we'll get you the phone number. There's an email address.
Okay. Perfect.
PICM@oasas.ny.gov. That is our managed care bureau. That's Pat Lingcourt. I think you've met
Oh, yes,
Pat.
I have.
Yes.
They are folks, they deal every day. We tell our providers, you know, if you have a complaint, let us know. We don't know what we don't know.
I know.
Yeah.
And it's unfair not
But
to
it's
tell
important.
you.
It's important that you email the questions in, and somebody will handle them.
PICM
Yep.
at
Oasis
oasis.newyork.gov.
You know, we have to close.
Okay. All
And I'm
right.
sorry we have to close. We could sit.
We could probably do another half hour.
It was really wonderful having you here and all the information. And I have to tell you, being in the field, what has transpired in the last couple of months really gives hope that we can change this and turn this around, turn this disease around.
Yeah.
With everything that's coming down the pike that's in law, with Narcan trainings, I really think we can make a difference. I really do. I'm hopeful.
Yes, we're hopeful.
Our campaign, we're going to still continue with our campaign, PSAs.
Okay, you are doing more PSAs.
Oh,
Yes.
absolutely.
Oh, that's
Absolutely.
great. That's great because they're big.
Yes.
Yeah, and that's part of it. There's so many people who don't seek help
I know.
for a lot of reasons,
Right.
and one of them is stigma.
That's
Stigma.
right.
Yeah.
They're afraid. They're
We're going to have to do
embarrassed.
another show on stigma.
Yeah.
And
Well,
I
the
want,
commissioners really led the charge on the campaign, the PSAs and other things being focused on stigma.
well, that'll be the next show that we
Yes.
do.
Okay.
Thank you very much. We'll see you again next week. Thank you.
Thank you.